So thank you for joining. We are going to be going over our outline for the week 8 content. It's eating disorders, sexual disorders, the aging individual, and neurocognitive disorders. So we're going to go ahead and get started. So I will be asking you guys, make sure you have your notes nearby because I'm going to be asking you guys to go ahead and put some of this stuff in the chat. I do already have the outline filled out, so I'll be copying and pasting from my own notes. And then if there's anything different, we can always add it, or this will be saved as like a Word doc and a PDF if you wanted to add it later. So feel free to take your own side notes as well. So what are some of our definitions for anorexia? How would we describe it? Do people with anorexia like have a healthy relationship? Okay, yeah. So fear of obesity, distorted body image, yeah. So body dysmorphia, fear of gaining weight, um, like you said, the distorted body image, so associated with negative body image, traumatic weight loss, low BMI, yeah. Yeah, they think they are. Oh, it's not on. Oh, geez, my keyboard wasn't on. Embarrassing. So these are some of the bullet points you guys already mentioned. Low BMI, fear of gaining weight, perfectionist, yeah, some other stuff that go along with that. What are, well, actually, I guess the BMI could be a manifestation, but what are some of the manifestations of anorexia? Fatigue, Manugo, right? Isn't that crazy? Like what babies have, the hair growth trying to keep themselves warm. That's what we're saying, like some anemia, maybe amenorrhea. How do they feel about the cold? Do they love the cold? No, there's some cold intolerance due to the lack of body fat. Along with amenorrhea, that could, because that's the absence of period, right? And then that could ultimately also impact fertility. How do our vital signs look? How do vital signs look? Low BP, low heart rate. Yeah, decreased heart rate, decreased BP. I also have menstrual rate as manifestations. They just think like the body doesn't have enough to work properly, so everything's just lower than you would expect it to be. The last thing that I added here that we didn't really mention, they would be like obsessed with food. So they might like hoard or conceal food. They don't really want people to know that they're not eating it, right? And then we also want to think brittle hair and nails due to the lack of nutrients and that dry skin. So I feel like all of these together paint a pretty clear picture of what a patient with anorexia may look like. Do we recall any of the criteria for hospitalization for patients with anorexia? Like if we're talking about low BP and low heart rate, like how low is too low? BMI, if it is a specific low BMI, I would have to go back on my notes for that. I do have something about like body fat percentages or body weight percentages. There you go, 85% less weight than supposed to be. That's one of them. So when we're talking about vital signs, we said low BP, low heart rate. So what's low? Like what's criteria for hospitalization when it comes to that? Yeah, electrolyte imbalances, severe. Is there a specific electrolyte we're thinking about? Yeah, potassium. Why potassium? Why are we always worried about potassium? The heart, arrhythmias, right. Alexis, is that systolic below 90, heart rate below 50? Because that's what I have. I also have a bullet point for some hypothermia. So a lot of times we might see people hospitalized for hyperthermia with a fever, right? However, in our patients with anorexia, we might see some hypothermia. So if they're below 96 degrees Fahrenheit. Anemia, this goes back to what Darren was saying. If they have, I think you mentioned red blood cells, but if we're looking at hemoglobin below 7, this is always like a transfused number right here. So they would most likely need hospitalization or at least a blood transfusion. Um, because low oxygenated blood throughout the body that leads to organ dysfunction, right? So we want to think about that. I want to say you guys hit everything here. So body fat less than 10%, body weight less than 85% of expected weight. And then also we would hospitalize if um, anything had progressed to like suicidal ideation. Anytime someone becomes a danger to themselves, others, or gravely disabled, it's a criteria for hospitalization. Pretty straightforward. So we just finished anorexia. Now we're going to move over into bulimia. So how would we define bulimia? Anorexia is like aversion to food, fear of being fat. Um, what are some defining characteristics of bulimia? Binge eating followed by purging or vomiting. Yeah, straightforward. Um, yeah, they might use laxatives, anything to just not have the food in their stomach, right? Rapidly ingesting food and then purging. Um, Now if we're talking about someone who might be like purging and throwing up a lot, what are some of those manifestations? Tooth decay. Russell sign. Yeah. Do you guys remember what Russell sign is? Yeah. They'll have like calluses on their knuckles from scraping their teeth, right? From making themselves throw up. Um, if we're painting the picture of someone who might be anorexic and we go back to our notes and we're talking about like emaciated, the nugo, brittle hair and nails, how does our patient that may have bulimia look? Similar? Yeah, like a normal weight. Yeah, so like their weight can fluctuate, right? So um you may not have that emaciated look that we see in anorexia. It doesn't mean that the illness isn't there. It's just that since they do ingest and then purge, they are still getting some sort of something to upkeep the calories, to upkeep some weight, and like the binging episodes, right? So just think of that differences in how they might present. The dehydration, I think Mary said. Again, irregular menstrual periods or amenorrhea. Again, electrolyte imbalances. If we're throwing up, we're throwing out potassium. Okay. Um, because at any time, and this is something that you'll tie back into um 232 and even 240 now when we're looking about acid base imbalances. Anyone that's throwing up a lot is at risk for metabolic alkalosis, okay? Because all the acid is getting thrown up, so our body becomes basic. So just keep that in mind. Metabolic alkalosis, Russell sign, which you already talked about. And here you just have a picture of it. You see the calluses right here on the knuckles. Other symptoms, secretive behaviors, excessive exercise, um, hair changes too. Okay, pretty straightforward. And what is our criteria for hospitalization for patients with bulimia? You'll actually find like a lot of them being the same, like low potassium would be the same, some hypertension might be the same, but there's a couple of different ones that might show up in bulimia because of like the process that if they're throwing up, they're kind of at risk for certain things. Does anyone have any ideas? every time like acid is just eroding. Um, I wouldn't doubt that they would have scar tissue. Yeah, I was looking more for esophageal tears. Yeah, because it's kind of eroding that GI tract, upper GI tract, right? And they might have esophageal tears. And then if they're throwing up, what if they throw up blood? Are we worried about GI bleed? Yeah, worried about GI bleed. They for sure need to be seen because we need to. GI bleeds are really hard to stop and hard to treat. So if there's any risk of GI bleed, they need to come in. Okay. So criteria for hospitalization again, that potassium can lead to arrhythmias. I'm not sure why it's separate, but it is in my head. And then they're at risk of like syncope due to hypertension, so they can lose consciousness anytime there's suicide risk again, and then those two. Okay. And we already printed out bulimia. So now to binge eating disorder. So there's a little bit more like specifics as to how binge eating is diagnosed. I don't know if you guys have that in your notes. But so the definition is just eating more than what most people would eat in a normal sitting within a 2 hour period. So, when we hear like, oh, I'm just gonna binge, just gonna keep eating, right? And then does anyone know the time frame of how long someone would have to binge eat for it to be diagnosable? It's at least blank a week for blank month. I don't know if they really got into this on the slides, but it is in your book. So they would have to do it at least one time a week for 3 months for it to be diagnosed, and it can usually be triggered by emotional distress. Okay, so I'm just gonna go ahead and copy that too. Some of our manifestations of binge eating. This might be the opposite of some of the other ones that we've talked about. So while anorexia might be emaciated, bulimia might look a little normal, normal sized or healthy weight. Someone with binge eating disorder may tend to be overweight, right? If they're just eating and eating and eating. And then they would also probably eat in secrecy. They would feel guilty or depressed after their episodes of binge eating, and then they'll be uncomfortably full after those binge eating episodes. So I'm going to go ahead and just put that here because, again, I don't really remember if this was in the PowerPoint too much, but I do remember it being in the book. Goals of care, I already put it into the outline. These are general goals of care for any individual dealing with an eating disorder. We want to prioritize safety, okay? ABCs always, because sometimes, like we mentioned, if we're going into when we're depriving our body of nutrients, we can be doing damage to the functions of our body, right? And then if we're anemic, we're a little concerned about our oxygenation. If we have tears, um, all of that stuff. So just even the body's ability, energy and ability to function properly, we're just always concerned about ABCs. Proper nutrition, obviously, we would need supplementation, some multivitamins, um, and then we would always want to address like the root cause, like what is causing the eating disorder. And a lot of the times there are some practice questions at the end of this outline, so I don't want to give too much away, but we have to think that oftentimes people may resort to eating disorders um, just for a sense of control. Okay, so that's just something to keep in mind as well. I don't know if Professor Gonzalez did the same thing to you all, but when we were going over the paraphilic disorders, she pretty much was like, I'm not really into this stuff. Like, we're not going to really talk too much about it. Is that what she said to you guys as well? Does that sound familiar? Okay. Um, so we'll just do a little bit here and there. We'll just talk about the different disorders and just a little like brief how to describe it. And then we'll move along into some other stuff. So for paraphilic disorders, what do you guys have for that? What's another way to say like a paraphilic disorder? Are you guys tired like me? Because I feel that. Let's all do each other. Let's copy and paste this. So it's a repetitive or preferred sexual fantasy. There we go. There you go, Mary. Yeah, repetitive sexual behavior or preferences. The one where you're aroused by an object. There is a type of disorder that is specific to what you put, Jackie. We'll get into that right now. So, most people, it does state that most people with paraphilic disorders are men, and the behavior is usually established in adolescence. And then most people who seek treatment are those with pedophilic disorder, voyeurism disorder, or exhibitionism. Okay, I don't remember this being too big of a part of the exam, but for some reason I do remember needing to know like at least a little bit of some of the paraphilic disorders. I'm not sure if that's still going to be the case. So, the first one we'll talk about is exhibitionism. Do you guys remember what that like desire, I guess, is? Exhibitionism. Yeah. Aroused by flashing. Yeah. So that's a desire to be exposed. We'll get to the one you're talking about right now, Jingle. Um, next, voyeurism is what Jingle put. So voyeurism is the desire to watch others. Okay. Next, we have, I'm just gonna put this. Okay. And then, this is the one that Jackie was talking about. The fetishistic is like usually a non-sexual human part or object. So that's the next one that's here. I know they're a little different to talk about, but we're just gonna get through it. So frotteuristic, you guys remember this one at all? Frotteuristic, arousal of touching a non-consenting person. Yeah, desire to rub on non-consenting people, however you would put that. Masochism, humiliated or hurt, yeah, mistreated, hurt, humiliated. Mm-hmm. Sadism, the opposite of. So if masochism is the desire to be hurt,
They hurt people, right?
sadism is the desire to hurt. And the last one is the transvestic, which is sexual gratification to cross-dressing. So, I don't think there's like you're not necessarily like diagnosing any of these things, but I do for some reason I really think there's at least one question mark. Like, oh, how would you categorize this? And it's like one of these descriptions, very straightforward. Like it's not, it's actually meant to be like more of a gimme point than like a gotcha point. So just think of that. We're gonna go ahead and get into gender identity versus gender dysphoria. So if we're talking about gender identity, what are some bullet points that you guys have in your notes about gender identity? It's the awareness of one's. Mhm. Did you guys get into this stuff at all? I can't. I feel like for this last like content, I don't think like the lecture was too much. Yeah, it wasn't, huh? Okay. But yeah, you guys got it. So It is the awareness of one's masculinity or femininity, and it's also the sense of knowing whether one is male or female. So that's under gender identity. And then we get into gender dysphoria. Oops, not want to do that. So then for gender dysphoria, um, there's a pretty straightforward definition to gender dysphoria. I think it comes like right off the slide. I'm not sure if you guys have your PowerPoint up or not. Um, but it comes right. And that occurs when there's an incongruence between biological or assigned gender and one's experienced or expressed gender. So that's dysphoria. And then that can be categorized by expressing significant distress in school, social, occupational, and performance functions for at least 6 months. So that's where it becomes more of a dysphoria situation, is when there's significant distress in school, social, occupational, and performance functions for at least 6 months. Okay. And then it's important to note that it's not sufficient just to make a diagnosis based on like someone's discomfort with the gender identity. That's not enough to categorize it dysphoria. Okay, just to note there. Um, I'm not gonna lie, guys, when it comes to the sexual response cycle, especially because I don't think she goes into it too much. I'm just gonna put it all here for you guys, and you guys can read through it. I don't remember there being a question being like, oh yeah, that was there, but still good to know, mainly because if this is a sexual response cycle, so if we're starting in desire, this is when I mean clearly this is a desire where um the desire to have sexual activity occurs um as it like pertains to stimulation, right? And then we have excitement phase, so this is where there's arousal, some physiological changes are here, okay? And then the orgasm is obviously the peak of the pleasure. Okay, we know this. And then resolution. So this is the after that, right? So if orgasm is not achieved, resolution may take several hours. Um, and it can also cause like pelvic discomfort. There's a couple like terms that may come to mind if we're talking about if it is not resolved, what we can go through, right? So that's all here. The important part of this mainly is to know that if this is the cycle of the sexual response cycle, then when we go into sexual dysfunctions, it's a disturbance to these phases. Okay, so that's the purpose of having that therapy. So if we're talking about um sexual dysfunctions that can occur, what are some that come to mind? Um, if we're talking about the sexual response cycle, what are some sexual dysfunctions that you guys can think of? Erectile disorder. We can also include like early or delayed ejaculation. And then there's one more. No erectile disorder? Oh, maybe there's more than one more. I didn't put that in my notes, but if you saw that on the side or in the book, yes to that too. It was more about the pain, so like endometriosis or like ovarian cysts and how that can relate to um the sexual response cycle if it's causing pain, right? Um, all we would really do in this case, in terms of education, we want to talk about the nature of the illness. So what is normal, what's abnormal, and then this is where we can explain the response cycle and maybe where the interruption is occurring. Is this high, please? Let's see more. Um, management of the disorder, so practices and ways of sexual expression, and then side effects of medications that may be contributing to dysfunction. So if we're going back to psychopharm and we're talking about some of our antidepressants, some of them can cause dysfunction, and that's why they might switch over to, is it the SSRI? Like I think SSRIs have um, less reports of sexual dysfunction, or if SSRI still cause it, then I think they go to SNRI, something like that. There's like a flow there, right? So some meds can also cause this. And then any support services. Okay. Like I said, they don't talk too much about it in lecture, and I don't recall it being a huge portion of the final. But doesn't mean don't know it. But I think it is just very like over. Um, okay. So now let's talk about the aging individual. So if we're talking about depression, in the elderly, there is an increased risk. It's 2 to 5 times greater. And I think your slide lists a couple different reasons why that might be, but there's like one big word that's pretty much in all of it. So why do we think the elderly are at greater risk of depression? There's like a lot of like blank of family, blank of losses. Yeah, exactly. There's a lot of loss. Um, yeah, someone put independence. What are some of the losses that they had? So I think I mentioned like family or like loved ones, especially a spouse, independence, work. What do we think about those that have like chronic illnesses? Loss of finances, loss of health, maybe, loss of mobility, loss of, I think that's it, status sometimes. Like if, depending on where they worked, if they had a very like, I don't know, significant role in a company or something, and now they're retired and they don't really have that kind of purpose anymore. So this all puts them at increased risk of depression. I want to see what this. Some of our risk factors, we already, if we're going back to our first like our first time learning about depression content, she says pretty straight up, like a very straightforward like demographic, like who's at greatest risk of depression. You guys remember? White males, what age group? Elderly, but more specific, over 65. And then we also are thinking that maybe if we're going back to loss of a spouse, maybe they're widowed or divorced. So there's just some isolation going on there, right? Alcohol use or chronic health conditions. So these are all risk factors of depression in the elderly. When we talk about management, what's some non-farm management of depression? What have we learned? I know you guys might not have those notes straight up, but we're setting for our finals, so this is a good thing. Yeah, group therapy, family therapy, CBT, yeah, cognitive behavioral relaxation. The last one, physical exercise. There you go. We're starting to get back into where we have our notes. Like, these are answering these more confidently. um, some pharmacological support for depression in the elderly. What are we thinking? For some reason, for here, I really only have like two specific farms, SSRIs, yeah, and TCAs, exactly. So if we're talking about an SSRI, what are some teaching points that we want to think about with SSRIs? Yeah, serotonin syndrome, that's fair. Especially because we don't know like how their renal function is, right? Yeah, hypermetry. Mm-hmm. Yeah, good job, guys. Pretty straightforward. We don't want them to be using diuretics with the SSRIs, okay? And then there's another, you said TCAs. This is where I have the anticholinergic, or like being mindful of orthostatic hypotension. Honestly, it's just always a safe bet. Anytime you have like an elderly patient, just bingo. I'm gonna have you sit at the edge of your bed for a little bit, okay? It's just always safer that way. We can also do ECT. So I'm just gonna put that here so you guys have it. Ah, that's fine. I don't know if this is any of you guys' first tutoring sessions with me, but I don't trust myself to type while you guys are all watching the way Diego does, so I have to copy and paste it because I get mad. Okay, now we're gonna go ahead and get into delirium. So what's our definition of delirium? Oh, I already have it here. Just kidding. An acute and reversible, that's important to note. Delirium is reversible, okay? Condition caused by an underlying condition. It is reversible. Not like some of the other neurocognitive disorders that we're going to see, okay? So delirium is reversible. What are some of the common causes of delirium? There's one that you guys hear a lot of. It's like the first sign of, yeah, UTI. Fever, illness, UTI, medication, substance withdrawal. Yeah. If we're talking about our elderly individuals or just anyone really, I guess, that's on a lot of different medications, there's like some risk for polypharmacy maybe. Like how do all of our drugs interact and environmental stressors? Yeah, all the stressors. And then also just like severe dehydration. I don't know if someone already said that, but as people age, we do lose our thirst reflex or it's like suppressed. So there's an increased risk of dehydration. Um, and it could, along with everything else, lead to delirium. Okay. So good job there, guys. And then what are our signs and symptoms? What would we see? What does that patient look like? Disoriented, disorganized, confused, agitated, yeah, irritable. Maybe they're a little restless. They might even like, yeah, paranoid. Exactly. I put fearful, but paranoid works too. Um, they're just really unsure, right? They're really confused, disoriented, all of those things. It could potentially progress to hallucinations. Okay. So it's important to be getting those like mental status exams on our patients. We always want to have a baseline at the start of our shift or know a baseline and then do our own assessment, right? So that we can see any changes in status. Um, good job, guys. And then when it comes to, oh, why did I keep some of the bullet points? Tactile and auditory. I really didn't get into specifics other than the fact that if they are in like a state of delirium, they can kind of lose sight of reality. So I'm not really, I would say yes, but I don't remember necessarily seeing it anywhere like for sure, other than it's just that state of like losing sight of reality, and then they're just at risk of those hallucinations, like not knowing what's real and what's not. Yeah. And if that was a question that came up, I probably would remember it because I tend to remember like test questions that scar me. So I don't remember that being fun. When it comes to interventions, the main way to resolve delirium, it's reversible. What's the main way to resolve delirium? Sorry. You'll actually hear this a lot. So whether it's for this situation or not, we treat the underlying cause. Yeah, treat the underlying cause. So yes, symptom management is also going to be important, but what is the underlying cause? Okay, so if it's a UTI, let's get them on some antibiotics. Let's get them hydrated, right? Same with dehydration. If it's polypharmacy, let's get a list of those drug interactions. Let's make some adjustments to their meds. If it's stressors, let's talk about that. Let's figure out like what are the triggers, what are our coping mechanisms, right? Important to note. Calming techniques, I like that. Yeah. That can help like reorient them for sure. What other interventions do we have? Actually, I think I just said a bunch of them. Sorry about that. So I think we already mentioned like restore F and E balance. So whether that means fluids or electrolyte replenishment, manage infection. Put this here. Okay, so this is all here for you guys. So treat the underlying cause, ABCs always, ABCs, restore family support, reorientation. If it's delirium, we are reorienting, okay? This is where jingles, oh yeah, safety always. ABCs and safety are always like number one. Tell the patient what you're doing. Yeah, I think that all goes with reorientation. Like, okay, this is what I'm going to do. Yeah. And then the two bullet points that were already there for you guys, but we'll just read them out loud anyways. We want to keep the environment arrangement consistent. So we don't want to like throw them out of what's familiar to them. And then we can always give anti-anxiety medications to help as well. Because if the stressors are sending them into delirium, if we're managing anxiety and stress, we're preventing the progression of delirium. Okay, guys, I'm not gonna lie, we're almost done. But there are some practice questions on this one that we can kind of go through together, and then we'll stop recording and we'll go. Okay, so for neurocognitive disorders, I just went ahead and left like this bare bones outline in here already for you guys. So it's like the irreversible confusion that is progressive and slow onset. So this one's irreversible. This one is reversible. Okay, just important to note. And then it can be primary or secondary. So primary is when it's like Alzheimer's or Parkinson's, which will just off the top of your guys' head, do you guys remember what neurotransmitters are involved here? What happens when a patient has Alzheimer's? What's going on with our neurotransmitters? There's like one in particular. Dopamine. Not so much dopamine, but low acetylcholine for sure. I have low acetylcholine. We have embarrassing how so to me. Okay, what about Parkinson's? I think Parkinson's is dopamine, isn't it? Yeah. Do it dopamine. Okay. Yeah, no worries. Honestly, though, guys, I would revisit your neurotransmitters. Okay, that's just always going to be a thing in psych. Revisit your neurotransmitters. Okay. Um, Secondary is usually caused by an underlying cause, so that's where we get into like alcoholism, HIV, traumatic brain injury, stroke, or vascular dementia. These can all also cause neurocognitive disorders. Okay. Cognitive impairment. So, within a neurocognitive disorder, it's the cognitive impairment of thinking, memory, reasoning, learning, and speaking. And then our goals, pretty straightforward, safety, ABCs. So this is where we have a risk of aspiration for sure. I don't know, were you guys still able to go to Artesia Christian at all? Was Artesia Christian your guys' first? Yeah. So I don't know, did you guys get the opportunity to work with any of the residents on the wing, the like I don't know if they call it, I don't know if they said it in a nicer way, but it was like the Alzheimer's, like or the neurocognitive side where they were like kind of behind the locked doors. Um, so did any of you guys help with feeding at all? Memory loss feeding? Okay. Did any of you guys help with feeding? Yeah. So I don't know about you guys, but I was really stressed out. I helped one gentleman in particular with his feeding, and I was, yeah, it was a long time ago. Look how far you guys have come. It's awesome, right? But he really wanted really big bites. He was like opening his mouth wide open for me, and I was like, I'm sorry, buddy. Like I can't give you a big bite. I'm stressed. But we're thinking about their ability to actually be able to like manage a big bite, right? And then yeah, I think I was just kind of going down a rabbit hole there. But there is a risk of aspiration, so we want to be careful of ABCs, especially if we're, giving medications or assisting with feeds or just even offering like oral hydration. We want to make sure we're being aware of that. And then we always want to slow the progression of the disease. And then we always, this is a big one, preserve dignity. is a main goal of nursing care. Oh, you guys already mentioned this, so I'm just going to go ahead and copy and paste it in. So in Alzheimer's, it's the decreased acetylcholine. And then do we remember any of the risk factors to Alzheimer's? Family history is one of them. Pretty very like obvious, just older age as well. And then there's actually some ties to cardiovascular disease. So the definition of Alzheimer's is the dramatic loss of ability to perform tasks that involve learning and memory. Okay. And then this is where I'm gonna have you guys kind of participate in the chat a little bit more. Do we remember the manifestations of Alzheimer's? They're a bunch of A words. And if you do put one in the chat, I would also like you to put what it means because I remember there being something about this. So one manifestation of Alzheimer's, like for example, I'll say one. Oh, just kidding, that's doing it. Yeah, amnesia, and that's memory impairment. Yeah, they can't remember. Do we remember another one? What about ataxia? Agnosia? Did I say it right? Yeah. Apraxia, misuse of items, right? Agnosia? Agnosia? I don't know what I'm saying. Loss of smell and taste. Yeah, or just all sensation, really. Pneumonia, inability to recall everyday objects. Yeah, guys. Did anyone put ataxia? Do you guys know what ataxia is? Loss of balance. Okay. And then lastly, aphasia, which you guys have probably heard a couple of times now throughout this nursing program. Aphasia. Maybe you're thinking more like a stroke patient. Yeah. So, inability to express or like speech. So then just an example of the apraxia is like painting with a toothbrush or brushing hair with a fork. Maybe like little there's two other manifestations. One called sundowning. It's seen in more advanced Alzheimer's disorder. And then does anyone recall like what sundowning refers to? Like what does that mean? Sundowning. Increased signs and symptoms in the evening. Yeah, so guys, pretty straightforward, okay. Um, Increased confusion, agitation, and restlessness in the late afternoon or early evening can lead to behaviors such as pacing, wandering, and mood swings. So that's again why that memory wing at our teacher Christian has those locked doors on that side. And then, do you guys recall what confabulation means? That's a memory. So making up memories, kind of, but a big thing that you want to like make note of in that is that there is no intent of deceit. Like it's a very honest, I don't know, like action. Like there's not, they don't mean to lie to someone. They really do think that that's like what happened, right? It's just not true. So I feel like this is sounding familiar. Um, okay. Now, when we get into stages of Alzheimer's, stage one is mild. So, what are some things that we might see in mild in stage one? What are our early signs, kind of more progressed? Did you guys get into Alzheimer's at all? in the content? I'm sorry, I literally make my outlines based off of my notes, and so I just feel like it's something that we talked about. Okay. Um, Forgetfulness. Yeah, that's one of them for sure. Do we think that they have long-term memory, short-term memory, recent events? Yeah, so forgetfulness. Short-term memory loss. And there may be some cognitive impairment in stage one. Okay. Now, as we go into moderate, it has progressed a little bit. So, what are some things that we might see in stage two or moderate Alzheimer's? Incontinence. Anything else? How do we feel about ADLs? Yeah, ADL assistance, and there might be some wandering. Good job. I can always tell where you guys came across like your notes for that part. The chat's more active. Okay, and then stage three, this is considered severe Alzheimer's. Bedridden, loss of yep, yep, ability to talk or swallow, might be good. And then what are our interventions for our individuals with Alzheimer's? What Think about their environment, think about their day to day. What are some things that we can do as nurses? Safety, yeah, I like that. Familiar routines. So we're talking meals, baths. Nickname? What do you mean? Like have them know you by oh you give them a nickname. Oh, okay, I didn't hear that one. You can add it to your folder. Oh, that works. It's in the PowerPoint. Um, cool. Yeah, safety, that goes into like keeping them from wandering. We want to reorient for sure, keeping instructions short and clear, and then for the PowerPoint. Okay. In terms of meds, the cholinesterase inhibitor, it improves. Did I put it in here already? So that can improve cognition, but it does not cure it. And so like as the disease progresses, it actually might be less and less um successful in treating. Okay, so I'm just gonna copy and paste this here because again, I don't recall the and then lastly, not lastly, almost lastly. We also just want to manage their other symptoms. So along with Alzheimer's, we might have to add some like antidepressants or antipsychotics or anti-anxiety meds to their medications. Okay, so that's the majority of what we had for today. I do just make a note about like a mini mental status exam. So this would be comprised of verbal fluency, comprehension, naming and word finding, orientation, and story recall. Ooh. Mm. Okay. So this is just what a mini mental status exam is comprised of. This is what we will be doing on any of our patients that have neurocognitive disorders, instead of the full mental status exam, if we already know their status. Okay. So this outline was super short. I know that. But it's also because it's only 1 week and you guys have already gone through a majority of the content. Okay. So you'll all have access to this. I am gonna switch over and let me let me stop sharing really quick. Questions that we can all. Do you guys want to do the questions on here, or would you guys rather do the questions on your own? Because I know sometimes it's like nerve-wracking to answer the question in the chat. but it's up to you guys. Okay. Let's just say what it's in here. Yeah, let's do it. And let me stop sharing really quick. To go ahead and get that situated. Mhm. Okay. Yeah. So one, share. Can you see this page with the questions in the bottom? Yeah, we're good. Okay. Let's go ahead and start with question number 1. So why would someone with bulimia nervosa have dental deterioration? 1, depletion of calcium stores. 2, acidic emesis erodes teeth. 3, purging causes a lack of chewing, leading to damage. Or 4, poor dental hygiene. Yeah, you guys are just on top of it. Number 2, correct, instead of B for some reason. But so the acidic stomach contents, and when you guys get this, you'll have the rationales to also look at. But like we mentioned, like our stomach contents are acidic. So that's why it erodes the teeth, which is also why if we're throwing up a lot and throwing up our acid, what acid base imbalance are we at risk for? Think ABGs. What would our ABG look like if we're throwing up a lot? I mentioned it earlier. You guys remember? This is just kind of to get you ready for med surg. It's not really site specific. Alkalotic, but what kind of alkalosis? Metabolic. Good job, guys. Okay. Just a jump start to med surg, okay. Number 2, why is behavior modification such a large part of treatment for eating disorders? 1, it fixes their issues with body image. 2, they address underlying anger. 3, they help manage uncontrolled behavior. Or 4, they allow the client to maintain control. Behavior modification. Anyone else? Good job. Yeah. Yeah, so you guys are right. It is to allow them to maintain control. I think I mentioned that when we talked about it. Issues of control are central to like the etiology of these disorders. So behavior modification techniques aid in restoring healthy body weight. We already talked about some of this, but what are some key differences between anorexia nervosa and bulimia nervosa? Think like how the patients present and yeah, just think differences. How would we tell the difference between the two? This is like an open-ended. It's not going to be multiple choice. Yeah, you're right. So that being said, if they're not eating at all versus if they're eating but then they're throwing it up, like what do they look like? Mm-hmm. Yeah, exactly. You want to think about that, right? It doesn't mean that there's not an eating disorder going on. It's just a different um pathophysiology, right? So in terms of behavior, Theron kind of hit it on the head. So anorexia is like severe restriction of food intake, while bulimia is binging and purging. Um, if we're thinking like how like physical health consequences, anorexia would lead to more visible signs of malnutrition, whereas bulimia's physical effects would be more like dental damage or electrolyte. Exactly. So like those telltale signs would also be different. Good job, guys. Good job. And if we're looking at the two, I mean, pretty straightforward, but maybe like bulimia nervosa would be a little harder to identify right away, right? Just maybe not. In diagnostic criteria for hospitalization for anorexia nervosa, what is considered excessive weight loss? Someone mentioned it when we first talked about it. Excessive weight loss. I'm not gonna lie, this question really confused me. So the answer, I'm just gonna give you guys the answer because I actually think it's kind of confusing. And like I had mentioned before, no shame, I reused Kaylin's questions because she's amazing. Um, but the answer to this is she puts a weight that is 15% or more below the normal expected body, which is confusing to me because what we know as the hospitalization criteria is 85, right? So I think that's what the question was trying to get at. Let me scroll back up so we can work this out together. So right here, if we're talking about criteria for hospitalization, it's that the body weight is less than 85%, right? So it's just another way to put it. That's how I look at this question. So diagnostic criteria for what is considered excessive weight loss, so it's greater than 15%, right? So let's select all the symptoms that are associated with anorexia nervosa. Your first data question. Hyperthermia, tachycardia, orthostatic hypotension, lanugo, increased respiratory rate, or amenorrhea. It's a SATA. Look at you guys, Mr. Champs. Um, since the body doesn't have a lot of like nutrients to work with, it'll kind of like slow down in an attempt to conserve its energy. So that's why vital signs are usually decreased during in these patients. And then it's usually hypothermia, not hyperthermia. And then since um like the body will also just kind of stop on what is deemed like a less necessary process. So that's why amenorrhea will occur. Um, we already kind of touched on this question comes directly from above, but does anyone recall off the top of their head what are some of the criteria for hospitalization in anorexia nervosa? Esophageal tear is more for bulimia because they're throwing up. So if we're thinking anorexia, what are our hospitalization criteria? Also, like if they need like a blood transfusion, maybe, electrolyte depletion, low BMI, severe depression. Yeah. There were some specific like vital sign criteria that we mentioned as well. Cardiac changes, so like arrhythmias. Yeah. You guys remember those vital signs? How low? That what's our systolic? Yeah, there we go. So systolic under 90, heart. Yeah, good job, guys. So that's all. And the answer to these below, they're in the rationales below, just so you know. So you would still have the answers, even though I'm not typing them. How long do you have to stay with a client with an eating disorder after a meal? 30 minutes, 1 hour, 15 minutes, or you don't have to. I can almost read that in Karen's way. Why do you guys think we need to stay with them? What are we looking for? Purging and bulimia? What would we look for in a patient that has anorexia nervosa? couple of days. Like any food discarding. Like we're just sitting there with them. Yeah. So guys, yeah, the answer is 1 hour. Ding, ding, ding. What kind of personality trait is associated with anorexia nervosa? Someone actually wrote this earlier into the chat. I think it was using wrong, but I could be wrong. What personality trait is associated with anorexia? Yeah, perfectionist. Mm-hmm. Pretty straightforward. Important to note. The client reveals to the nurse that I'm turned on by little girls, not adult women. This statement supports which possible diagnosis? Yep. Number 3. Move along. A male client explains that he is heterosexual but prefers to dress in feminine clothing. This characteristic behavior is suggestive of what sexual disorder? Yep. So these are all pretty straightforward, right? So that's what I mean. Like, I think there might be a couple questions where you're kind of categorizing it, but it is as long as you have a general idea. Um, a client has been diagnosed with gender identity disorder. The nurse can expect that the client will evidence which characteristic. Yeah, so there might be some discomfort with the biological gender because it has that incongruence, right? So that is the correct answer there. If we're talking about the differentiation between sexual disorders or the paraphilic disorders and sexual dysfunction, how would you guys describe that? What's the difference? One relates to something, whereas dysfunction relates to, it's not really black and white, but I'm just gonna read it out to you guys because it's kind of hard to put. Once you hear it, you're gonna be like, yeah, I knew that, but it might be hard to like think to put it in those words. So in terms of sexual disorders, we're looking more at like behaviors, right? So all the ones that we had talked about already. So those are inappropriate sexual behaviors, whereas dysfunction is an impairment in the normal sexual response. So like I said, you think of the phases, you might not have to memorize the phases, but what you are gonna know is that dysfunction is disruption in those phases, right? So disorders, inappropriate behaviors, dysfunction, interruption in the normal sexual response. Okay. Number 13, a nurse is assessing a client diagnosed with fetishistic disorder. What would differentiate this paraphilic disorder from protoristic disorder? So these are wordy, so I'm just going to let you guys read through them. So we're talking about fetishistic versus protoristic. Guys, it is number 1. So fetishistic is the non-living objects, whereas protoristic is the rubbing against non-consenting. Mm-hmm. So what is the biggest difference between delirium versus neurocognitive? You guys know this. I highlighted it. Yay! Good job. Delirium is reversible, and neurocognitive is not progressive and reversible. Acute and reversible versus irreversible, progressive. Mm-hmm. Let's see how. Number 15, a patient with Alzheimer's disease is having trouble performing the movements needed to use their toothbrush for mouth care. This is described as movements. What pertains to movement? Yep, good job, guys. Apraxia, so it can affect speech, movement, and so forth. So Job, you guys got that one. This is what I mean. Just know enough to be able to categorize, okay? You're helping a patient with hygiene. The patient is having trouble asking you for a particular bathing item. The patient wants the soap bar but makes up a name for the item. This is known as what? I have anomia for this one because they just can't recall what it is. Anomia. Okay. And the last question, a patient with severe Alzheimer's disease is prescribed to take Namenda. Which statement best describes how this medication works to treat this disease? I know we didn't talk too much about this. I think this is probably like a simple nursing question or something, but let's just take a guess. Because we know what neurotransmitter works on Alzheimer's. Let's see, you know. So, you know what, guys? I think I led you astray. Because you're right. Like, they would need increased acetylcholine. However, that's not how this works. So, my bad, my bad. Um, Yeah, it is number three. Why'd you guess that, Jackie or Diane? Both of you guys did that one. You guys just remember, or was it a lucky guess?
I read something about the MDNA receptor.
Oh, perfect. Well, it worked here. So, yeah, the rationale, excess NMDA. You know what? Let's add that to our outline so that we have that here. The medication. I'm gonna add it. Yes. Good job, guys. I wrote that into like where I had the meds on the outline, and then for Alzheimer's, I'm just gonna put. And under a neurotransmitter, I just added it there just so you guys can all piece it together, okay? I know it's not necessary. Cool. Okay, guys. That actually concludes our outline for today. Let me go ahead and save these for you guys. I'm gonna stop showing because I just did that. Um, I'm also going to go ahead.